Yeah, this is going to make assessment of various DBS targets very challenging to include not only the motor components, the non-motor components, type of dystonia, all the other variables. It just makes me think of Charlson comorbidities that we deal with in other chronic disorders like Parkinson's. Do we need to consider whether there's been COVID, for example, for this cycle and all of these other issues?
Yeah,
I think some other questions. Oh, go ahead, Buzz.
I was thinking back to one of Cindy's slides where she showed the Revan study with the long-acting Daxi, and the 125 unit dose did better than the 250 unit dose. One wonders why that would happen. It seems very feasible that the 250 dose was actually contaminated by non-motor concerns, and so the score was actually lower because the side effects were mixed with the motor outcome. Obviously, the docs were doing the Twisters rating scale, but they are, of course, going to be influenced by what the patient tells them. You know, oh, I'm doing better, so then the score should be better. Oh, I'm doing terrible, and the score should be worse. So I kind of wonder if that was the explanation there. I don't know if Cindy's still with us, if she can provide some insight into why that was, the dose effect was a little weird.
Go for it, Cindy.
Between the two groups.
You're not coming through very well, Cindy. Just a little closer to the microphone, please.
Okay.
There
Now,
you go.
can you hear me?
Yes.
The side effect profile was a little higher in the higher dose group, but not that much. I don't know that AE would account for it. What I do think it accounts in part for it is that the study wasn't really powered.
Stay closer again, please.
The study was not really powered to compare the 250 to the 125. And so it's really hard to make any conclusions based on that. It happened in the intravitric toxin trial as well, where the low dose looked like it could be superior to the high dose. And yet those of us who have used it find that that's not necessarily true. So I don't think you can draw any conclusions from that particular study about comparing one dose to the other.
Yeah, Cindy, your audio's cutting in and out a little bit. What I heard is you can't draw any conclusions. It wasn't, the study wasn't powered to detect difference, but one would at least expect the trend to be logical. So,
but in other studies, it's also not been.
Yeah.
So in the INCO study, it was not, again, the lower dose was superior to the higher dose. That was not, I mean, that's not clinical practice.
Right. And Mark Hallett raised the question, did you have overdose with the toxin at the higher dose? Were there any side effects, too much neck weakness, for example?
Not appreciably so. Again, they weren't powered to compare this, but the AEs in both a little higher in the 250, but low overall compared to other toxins. So I don't know that was the reason. There could be other reasons, and perhaps at 125, maybe that is the dose. But I don't think from that particular study you're able to say anything with any certainty.
Thank you. Marie brings up an interesting question regarding TMS. Would it be useful to target not necessarily just the motor or premotor, but what about the targets used for treating depression by psychiatrists to improve non-motor symptoms and in between anxiety and discomfort during the waning and waxing effects of botulinum? Anybody want to take a shot at that?
Yeah, maybe I'll say a little something and then maybe Aparna can jump in as well. I think she probably has some thoughts on this. I think, you know, one of the great points that this brings up is that maybe we shouldn't have a one-size-fits-all treatment approach, that there may be different treatment approaches at different times of the cycle, as well as if we use botulinum neurotoxin as our primary therapeutic modality. But we should also address, especially at certain points in the cycle, other comorbidities that will be going on or could be worsening at that time. So I think that's a really nice question, and to my knowledge has not been approached in exactly that way as using TMS, but I think it's a really very nice thought that maybe one treatment doesn't solve all of these problems. And Aparna, maybe you have a thought.
I totally agree with you, Sarah, that we have to customize and individualize the treatment. And I think the idea of using TMS over the dorsolateral prefrontal cortex is a fantastic idea, especially with the availability of the accelerated protocol, where we can give a lot more sessions, because previously the treatment of depression was spread over 6 weeks, and then it took some time. We needed at least 20 sessions. But at our center, we have some small pilot studies ongoing using the accelerated protocol, where we can give 3 or 4 sessions in a single day and try to wrap it up over 1 week. And I totally agree that dorsolateral prefrontal cortex should be targeted, because that is one of the critical nodes for the depression network. So definitely we should look into that.
And as Janet has a follow-up question in that regard, what do you think the future of modulation or stimulation, non-invasive stimulation is for treatment of dystonia?
I think as an add-on treatment, it is definitely underutilized. And, because for the DBS, for example, we are targeting only the specific nodes, and that too in the nodes in those network, we are targeting only the motor circuitry, the motor loop, the sensory motor loop. And as Joel, you brought up, how do we address the non-motor symptoms? Because we are not really even spreading the electrical fields in those areas. So to address those issues, we could definitely leverage some of the non-invasive techniques. RTMS may be a little bit contraindicated in the presence of the DBS hardware. However, TDCS, TACS, those modalities could definitely be implemented as add-on treatments with DBS to address the non-motor symptoms.
And is there any information about, with the non-invasive stimulation, about interactions in targeting different parts of the brain? It's going to depend very much on which targets are there, but if we have any information about that.
So previously we used to think that if we target a specific surface region, for example, TMS or RTMS, previously we thought that if we target a specific location over the surface of the brain, and that was the area that was going to be most affected. But now with the availability of advanced functional MRI, we know that we can actually spread the effects to even remote areas. It has all these spread of effects affecting the other nodes. So I think, as I said earlier, it's definitely underutilized.
Thank you. And as Noreen just pointed out, she's going to address this in greater detail tomorrow at her talk. Well, I think that's been a great discussion. Ready to move on. Buzz, do we have anything else at this point? I think we're good for the day.
Joel, I think you have taken us to the end of our agenda for today. You're right. So I think we should just thank all the speakers. I really appreciate everyone putting this together. I want to thank our technical team, folks at the DMRF, particularly Jinnah for making this all work, and Janet. I think it's went very, very smoothly today with no technical glitches, which is, I think, great. Joel, did you have anything else you wanted to finish with?
It was all very good, and they muted me at the appropriate times. I appreciate it.
All right, great. Well, it's 4 o'clock. We're at the top of the hour, and that's the end of today's agenda. So we'll be back tomorrow at the same starting time, which is 1 p.m. Eastern Standard Time. And please come prepared with your questions. If you have any that you thought of during today, go ahead and put them in email. We're going to probably turn the Q&A and chat off, so we won't be monitoring it anymore. But I thank everyone for joining.
Eastern Daylight Time, Buzz.
Eastern Standard Time. Eastern Daylight Time.
Thank you.
Eastern time.
Eastern.
Correct.
All right, thanks, everyone.
Bye-bye.